Next speaker is Dr. Sony George, Circle Head of Dr. Agarwal Eye Hospital in Kerala. He's talking about dealing with nucleus drop, tips and tricks. Over to you.
Thank you, Jacob. At the outset, let me thank Dr. Sandhya for enough cataract surgeries, that's all. At some point in time, you will have at least a fragment drop once you cross a significant number. And obviously, at any stage in life, it is going to be a nightmare for you. And what could be the causes? It's always a better idea to avoid such situations as much as possible. So it could be a peripheral extension of an anterior capsular tear, or an incomplete rhexis, or going in for a wraparound PC tear. It could be from a second instrument, so always be careful with the second instrument not to cause damage to the capsule, anterior or posterior. Aggressive phacoemulsification. The settings, you overestimate the grade of the nucleus, and then you go ahead and you end up in damaging the posterior capsule, and then subsequently nucleus drop. Aggressive phaco settings and predisposing factors. So earlier it was only the posterior polar cataracts, but with the number of intravitreal injections, which is even done by most of the anterior segment surgeons also these days, the chance of a lens touch and a subsequent inadvertent pre-existent PC rent is a possibility. So aggressive phaco is could be one of the reasons. And see, the surgeon is going very aggressive. Actually, it's going to the periphery and using a lot of energy. And you can see he ends up with a large posterior capsular tear with a significant amount of nucleus still remaining. The first thing you should do is not to pull out the instrument. Very, very important. If you see something like this happening, to reduce the amount of damage, to tamponade the vitreous from coming up, you should never come out. Push in viscoelastic like Viscoat, plug the posterior capsular rent as much as possible, and then go ahead with cataract surgery. And bevel down phaco, nowadays most of us don't do that. Okay, again underestimation, overestimation of the hardness of the cataract, and then you end up in a rent. So what are the warning signs? So first of all, we should try and, instead of dealing with the dropped nucleus, you should look at the warning signs. And one of the major signs is when the nucleus stops rotating during the cataract surgery. It's a very important sign. Stop, think, and then go ahead. Suddenly a deepening of the AC, or if there is a decentration of a heminucleus much beyond what you would expect, vitreous strand, and obviously dropped lens fragment, then if you continue, it is disastrous. So don't ignore these signs. So this is one such situation in which the surgeon is making a trench, and then he has a doubt whether he's caused a PC rent. So he tries to separate, and then he sees a suspicious PC rent there. When he tries to rotate, see, rotating and the pieces just bouncing back. This is a very important step, indication that there could be a PC rent. And here again, the pupillary slap sign, or the AC deepening. See, while he is going deep, suddenly now the pupil is snapped and the AC has become deep. Very important sign. Okay, this is the dislodged heminucleus. See, half the nucleus is removed. You can see it is tilting, slightly tilting. So it is the clear area is seen on the right side, and this is a major indication that you are in a soup. Okay, then obviously this is the nucleus drop. You know, he is trying to pull a peripheral, and this thing is already dropped. So again, instead of pulling out, you should put viscoelastic, plug, and then go ahead. So what do you do? At this point in time, there are two things. One is your cognitive skills and your surgical skills. Both have to be used. And do not panic. First of all, do not pull out the instrument do an OVD exchange, take a minute, gather the information, okay, what exactly is going on, assess the situation, take a decision. If you are a God-fearing man, you can even pray for a minute and then take a decision, have a plan, and then go ahead. So if it's an early PC tear, the first thing is do not harm, do not cause more harm. That's why I said do not pull out. The moment you pull out, the PC tear is going to extend. You can even have an immediate drop of the nucleus or the nuclear fragments. So always, do not deflate the anterior chamber, put in viscoelastic, plug the PC rent and avoid vitreous coming up, stabilize the fragments. Whenever necessary, if you are not able to bring up the fragments into the anterior chamber, then use a dry vitrectomy and if necessary, use triamcinolone. The larger fragments can be visco-expressed. You should also do a cleanup vitrectomy. Don't stop with just removing the fragments. Try and remove as much of the cortex as possible using a vitrectomy IA switch. You can decide whether to implant an IOL or not. If it is a full hard nucleus which is gone in, and if you think your vitreoretinal colleague may need to float it up with the PFCL and bring it through the main section and remove it, don't put an IOL. In all other cases where you think the VR surgeon can remove it with the fragmentome, place an IOL, do a thorough vitrectomy, let there be no vitreous, place an IOL, do a PI, and do a final check with a triamcinolone. And always respect once you're doing a vitrectomy, do not pull on and this can cause a traction on the vitreous base and that can be disastrous. And you always use a low cut rate, low vacuum and a high cut rate in these cases. So here, sometimes it can be a false alarm. Like in this case, there is a suspicious PC rend here, but then you see the surgeon tries to confirm it by rotating the nucleus. He just puts in viscoelastic and he rotates. And once it rotates freely, then you don't need to worry. See, it is freely rotating. You can go ahead with phacoemulsification. And here again, and this is a early fragment drop, okay? So he tries a peripheral chop and it is going into the periphery and he doesn't realize, he keeps on rotating. It's not rotating. He keeps on attempting this one and then you have a sudden fragment drop. And by the time it is evident, all the damage has been done. See, now he's again trying to rotate and the fragment is dropped. So in these cases, you have to go in, try and remove stabilize the pieces, remove it. You can put an IOL in the sulcus because the fragment may not be needed to remove. And then at the end of the case, he'll have equally good vision. Do a PA also. And yeah, in larger pieces, you can go ahead, extend the wound and then remove it. And here again, it's a nucleus drop into the periphery. And here, so at times, you may need to do a pass plane. Always stabilize, use triamcinolone if necessary. Yeah, and do a vitrectomy and continue. And here a PP vitrectomy is necessary because a large tongue has been remaining in the posterior this thing. And you can place an IOL in the sulcus and then use a fragmentome. And to avoid an undersized rhexis, try preventing a second instrument trauma and avoid peripheral or a phaco push in the periphery. And in late phaco, it is because of your settings, post-occlusion surge, aggressive phaco. You can see the peripheral tear very clearly because there's nothing else. Like in this case, you can see there is a rent which has happened. Again, similar picture. So in late cases, management, you should recognize the complication, always do an OVD exchange. If possible, control the tear into a PCC. Use triamcinolone to confirm that all the vitreous has been removed and then you can use your listen. For example, in this case, you see a rent and then instead of pulling out, you put in viscoelastic so that the tear doesn't exist and then go ahead. So the OVD exchange is very important. And in this case, after implanting the IOL, just make sure that all the this thing is removed. You can be little more luxurious in using after putting the IOL, because nothing much will go into the posterior chamber, the posterior segment now. Yeah, yeah. So to prevent, go for softer settings for the final, stay central and bevel up. Thank you very much for our
Thank you,
patient
Dr.
here.
Sony, for that very informative talk. So because of the positive time, we'll take discussion